President ma'am and Secretary sir, and let's start a program.
Sir, am I audible?
Yes, you're audible.
Okay, sir, with your permission, I'll start.
And Secretary sir, and let's start a program.
Sir, am I audible?
Yes, you're audible.
Yes.
You're audible.
Okay, sir, with your permission, I will start. Deliver. Slow. Okay, sir, I'm starting now.
Yeah.
A very good afternoon to everybody present. I am Dr. Arslan Reza, PGT Pediatrics, Diamond Harbour Government Medical College. Here I begin my case. Common fever, uncommon presentation. A 9-year-old boy from Mogra Hat. One second, sir. Minimize করা যাবে আর এটাকে একটু উপরে যাবে
Please continue.
Please
sir.
continue.
Yes,
Please
sir.
continue.
A 9-year-old boy from Mogra Hat who was admitted on 8th of May and examined on 9th of May, informant being mother. Slide is not moving. Okay. The chief complaint of the child was fever for 7 days, lower abdominal pain for 5 days, pain and swelling in the scrotum for 5 days. The child was apparently well 7 days back. Then he developed fever, which was insidious in onset and of low grade and in the beginning. And later on, it was high grade, intermittent, and was associated with chills. The fever decreased on taking medication. 2 days after the fever, he developed lower abdominal pain along with pain and swelling in the scrotum. The pain became so severe that the parents have to bring the child to the hospital and get him admitted. Abdominal pain was intermittent and colicky in nature, aggravated on taking foods, relieved on taking medication. The scrotal pain and swelling were more on the right than left. There was no history of trauma to the scrotum and no urethral discharge. There was no history of dysuria, increased frequency, or any burning sensation on micturition. There was no history of loose stool or jaundice. There was no history of cough, cold, or respiratory distress. There was no history of any similar illness in the past. There was no history of any major ailment or surgery in the past. Nothing significant was found in family history, birth history, immunization history, developmental history. Nutritional history, predominant non-vegetarian diet, daily calorie intake was 1500 kilocalorie, daily protein intake was 10 gram. Daily dietary intake was inadequate as per the weight of the child. This is the photograph of the child on the day of admission. On examination, general survey, child was conscious, alert, and cooperative. Anthropometry, weight was 20 kg, height was 122 centimeter, BMI was 13.4 kg per meter square, which was between -2 standard deviation to -1 standard deviation as per the IAP growth chart. The facies was normal, decubitus of choice. Pallor, cyanosis, icterus, cluving, and edema was not found in the child. Skin and hair were normal. Pulse 122 beats per minute, otherwise normal. Temperature 101 degree Fahrenheit. Respiration 28 per minute. On examination of the lymph node, cervical lymph nodes, multiple lymph nodes were enlarged in the submental and submandibular region and posterior triangle. The nodes were soft, tender, discrete, and mobile. Largest one measuring 2 cm on the submandibular region was noted. Axillary lymph nodes. Multiple lymph nodes were enlarged in the apical, central, and lateral region with an average size of 1.5 cm. The nodes were soft, non-tender, discrete, and mobile. Inguinal lymph nodes. Multiple lymph nodes were enlarged in the oblique and vertical group with the largest one measuring 2 cm. The nodes were soft, discrete, and markedly tender. They were not fixed to the superficial skin. Lymph nodes on all the other sides were not palpable. There was no swelling of the parotid gland. No Ishkar was found on examination. Now moving on to the abdominal examination. On inspection, normal in shape, umbilicus inverted, flanks are full, no superficial vein visible. Moving normally with respiration, right scrotum appears to be larger than the left. On palpation, surface temperature raised, no tenderness on superficial palpation. Tenderness present on deep palpation in the right and the left iliac fossa. Bladder is not palpable. Liver is palpable 4 cm below the right costal margin in the mid-clavicular line. Soft in consistency, round margin, surface smooth, with no palpable left lobe, with an liver span measuring 12 cm. Tip of the spleen was palpable on deep inspiration. On palpation of the scrotum, tenderness was present, which was right more than the left. Here we can appreciate the swelling of the uh, right testis more than the left. Other systemic examination, that is respiratory, CVS and CNS, were otherwise normal. So summarizing the case, we have a 9-year-old boy presented with high-grade fever for 7 days associated with pain in the lower abdomen and scrotum for 5 days with palpable liver and generalized lymphadenopathy. So what are the possibilities? Scrub typhus, infectious mononucleosis, and typhoid fever. On performing the investigations, complete blood count, hemoglobin was 9.5 gram per DL. Total leukocyte count was 7,900 per cubic millimeter. Predominant neutrophils, platelet was 1.79 lakh per cubic millimeter. Urine REME, no abnormality was detected. Urine COS, no growth was seen in 24 hours. Liver function test and renal function test were normal. Vidal was negative. Dengue IgM non-reactive. MPMPDA was negative. Scrub typhus IgM was reactive by ELISA. On performing the USG whole abdomen and the inguinal-scrotal region, USG whole abdomen revealed liver enlarged 14.5 centimeters, spleen 11.5 centimeter. Multiple enlarged inguinal lymph nodes are noted. Right side epidermis appears thickened and echogenic with raised vascularity. Right testis enlarged in size and showing increased vascularity. Reactive hydrocele noted in the right scrotal sac. Scrotal skin thickness increased. Left scrotum appears to be normal. Here we can see the color Doppler study of the right testis, and we can appreciate there is the increased vascularity of the right testis. So the final diagnosis is scrub typhus with epididymoorchitis. Child was treated with injection ceftriaxone and oral doxycycline. Fever and pain subsided in 48 hours. So scrub typhus is an acute febrile topical illness with varied multisystemic presentation. It commonly affects gastrointestinal, neurological, and respiratory systems. Epididymoorchitis, a rare manifestation of scrub typhus, which was first reported from South India, and here is my reference for that. So the take-home message: child presenting with orchitis and high-grade fever with lymphadenopathy, think of scrub. No need of additional treatment for the scrotal pain and swelling. Only doxycycline was enough for the rapid improvement. So with this beautiful smiling picture of our patient on the day of discharge, I'd like to say thank you to all of you for your patientful hearing.
Thank you, Arsenal. Thank you, Arsenal, for your nice presentation. We'll discuss the discussion part at the end of presentation. So I would like to invite the next speaker, Dr. Tanmoy. Please, over to you, Tanmoy.
A very good afternoon to everybody. I am Tanmay Vishwas. I am presenting my case, fever with rash, think rationally. A 6-year-old boy previously diagnosed case of type 1 diabetes mellitus on regular insulin 332 and glargine 2 at bedtime was admitted with high-grade continuous fever for last 5 days. Fever was associated with several bouts of vomiting, pain abdomen, mild redness of eyes, petechial rashes over the trunk, and bleeding from the lips and gums. A black lesion noted over the forearm. This is the picture of the boy at the time of admission of our hospital. There was no history of cough or any respiratory tract infection, no history of burning micturition or jaundice or bleeding from any other site, no history of joint pain or difficulty in joint movement, photophobia, ear discharge or convulsion. There was no history of travel in last 1 month, no documentation of COVID-19 infection in last 1 month. So what are the possibilities? Possibilities may be dengue hemorrhagic fever, MISC, scrub typhus, enteric fever, meningococcal infection, septicemia with underlying infection predisposed by pre-existing diabetes mellitus. infection associated HLH, acute presentation of leukemia. Then we go to the examination. On examination, patient was conscious but extremely sick looking, lying on the bed with very little movement of his limbs. He was responding to the command, but GCS was 15/15. His eyes were congested and petechial rashes were noted over the tongue. A small black lesion over his left forearm was noted. Vital signs: pulse rate were 120 per minute with regular rhythm without any radial or radiofemoral delay. Respiratory rate was 30 per minute, which was abdominal in nature. Temperature was 104.5 degree Fahrenheit. BP was low, 70/60 mmHg with narrow pulse pressure. Saturation was 99% at room air. Tourniquet test came positive. Patient was presented with mild pallor, but there was no cyanosis, edema, or icterus. No lymph node enlargement were noted. Patient had bilateral congested eyes. On palpation of the abdomen, we found tendon hepatomegaly of 4 cm from lower costal margin. No meningeal sign, carnic signs, or any other signs of CNS involvement were noted. Ophthalmological examination was unremarkable. On the basis of history and clinical findings of low BP 70/60 mmHg with narrow pulse pressure and positive tourniquet test and tender hepatomegaly, we diagnosed the case as dengue hemorrhagic fever and started the fluid management immediately. Investigations were sent and report pending. The fluid management started at the line of dengue. IV NS bolus at the rate of 10 ml per kg per hour for first 1 hour given, then 7 ml per kg per hour for 2 hours, then 5 ml per kg per hour for next 4 hours, then 3 ml per kg per hour for next 40 hours. As the patient improving gradually, we stops the fluid after 48 hours of starting fluid. Other symptomatic managements like infusion paracetamol, injection ceftriaxones were given. We encourage the parents and child for ORS and paroral fluid intakes, and counseling of the parents were done to inform sudden onset respiratory difficulties or any other difficulties. Intake and output chart and temperature chart was maintained. Regular hemoglobin, hematocrit, and platelet levels were checked. Meanwhile, investigation reports are available. So we see the investigation that CBC is in hemoglobin is 10.6 gram per DL, platelets is 90,000 per microliter, TLC is 60,000 per cubic millimeter, and PCV is 30%. Blood sugar random 168 milligram per DL. ESR was 64 millimeter in first hour and CRP was 46 milligram per DL. On peripheral blood smear shows RBC shows hypochromic microcytic anemia, no immature precursor in the peripheral blood smear. And urine REME shows pass cell 20 to 30 per high power field. On day 2 of admission, platelets further reduced 50,000 per microliter and PCV 32%. LFT shows ALT was more than twice the normal, that is 98 milligram per DL, and other liver enzymes were within normal limit. MP, MPDA, scrub IgM, typhi.IgMs all are negative. So, and COVID IgG were also negative. So it's rule out the MISC. Dengue NS1 was positive and IgM came equivocal asking for repeat testing. Blood and urine culture sent both came sterile after 3 days. On day 3 of admission, patient improved hemodynamically after fluid management, but high-grade fever continued. Platelet decreased to 40,000 per microliter along with bleeding, so it requires platelet transfusion. HLH workup was planned, but some new clinical findings appear which were absolutely unexpected. What are the clinical findings? Perianal discommission, periangual discommission in the hand, and periangual discommission in the foot. So now it is evident that non-remitting high-grade fever, bilateral conjunctival congestion, periangual perianal discommission in the second week, raised ESR and CRP, sterile pyuria, all are point towards the coexistence of Kawasaki disease. So we go for an echocardiography immediately. Echocardiography shows dilated LMCA 2.6 millimeter, otherwise normal, that's suggestive of the Kawasaki disease. In dengue with Kawasaki disease, diagnostic criteria for Kawasaki disease appears from day 7 of the fever, as shown in the Piyush Gupta et al. Case publication, which is similar to our case. The reference for our case is given below. Concomitant dengue hemorrhagic fever and Kawasaki disease overlap of both disease could account for the lack of typical changes in the platelet, that is the thrombocytopenia in dengue hemorrhagic fever and thrombocytosis in the Kawasaki disease. So we treated the Kawasaki disease with IVIG 2 gram per kg was administered on the day 9 of the fever, and her redness of the eyes disappeared within 24 hours of introduction of the IVIG. Fever subsided completely. Platelet count on the day 12 was 1.8 lakh per cubic millimeter, and it was not as high as in Kawasaki disease in the second week, as mentioned previously. Repeat echocardiography after 7 days of the first echo was found normal. A small episode of hypoglycemia was noted in the second week of this disease. That is, his blood sugar level was fluctuating with hypoglycemia documented with CBG 30 milligram per DL in early morning. The insulin dosage was modified to regular insulin 222 and glargine 2 at bedtime. At the time of discharge, he was hemodynamically stable and maintained normal blood sugar levels. So he was advised for follow-up at our OPD for Kawasaki disease and diabetes mellitus. Advice on discharge, we given this advice is that diabetic diet, live vaccines are not to be administered for next 12 months. Tablet aspirin 75 milligram, one tablet once a day after breakfast to continue. Echocardiography for coronary artery status after 6 weeks. Regular insulin 222 units subcutaneously and glargine 2 units subcutaneously at bedtime. So take home message: persistent of high fever in dengue even after the critical phase should raise the suspicion of coexisting illness. Clinical features of the Kawasaki disease may not be very much evident in the first week, especially in case of incomplete Kawasaki disease, and could be undetermined by the features of other coexisting illness. Usual thrombocytosis of Kawasaki disease in the second week did not occur here due to thrombocytopenia already caused by dengue. So I end my presentation with a thank you.
Thank you, Dr. Tanmay, for your nice presentation. There is one question at the Q&A. So basically, we'll discuss the Q&A.
Rahul, unmute yourself. Rahul, unmute yourself. Unmute. You are not audible.
Yes, sir. Yes, sir. Yes, sir. Thank you, sir. So there is one question. So we'll discuss the question Q&A at the end of presentation. Next presentation will be by Dr. Akhilesh Kumar Singh. I would like to invite Dr. Akhilesh. The topic is recurrent fever, rare diagnosis. So now over to you, Dr. Akhilesh.
Thank you, sir. Good afternoon to everyone. I, Dr. Akhilesh Kumar Singh, second year DMD Pediatric PGT at Diamond Harbour Government Medical College and Hospitals. Today, I am going to present topic recurrent seizures, a rare disease. 15 years old boy who was a unknown case of the seizure disorders, presented with the breakthrough seizures and acute slurring of speech. He was symptomatic from his age of 12 years. He was under anti-epileptic medications for the last 3 years. Patients complains of the progressively increasing episodes of the muscle spasm and uncontrolled movements, along with acute slurring of speech and some behavioral problems. There was no family history of convulsions. birth history, developmental history, uneventful, immunization history up to date. Examinations. Child is alert, conscious, faces normal, no pallor, cyanosis, icterus, clubbing and edema was noted. Lymph nodes not palpable, vital signs are normal. CNS, respiratory, and CVS with abdominal examinations are normal. Head circumference was normal up to the age of 5 years. Nutrition status good for the age. On examinations, no skin lesion found. What could be the possibility from the above features? It may be the neurodegenerative disorders. It had seizures and extrapyramidal symptoms. It may be the gray or white matter degenerations. So let's check investigations. Abnormal report of the plasma parathermone high, value 180.4 picogram per ml. Range normal range is the 50 to 65 picogram per ml. Low serum vitamin D, value is the 27.9 27.3 nanogram per ml. Optimum range is more than 30 to 100 nanogram per ml. Low serum calcium, value 6.1 milligram per 100 ml. Range 8.7 to 10 milligram per 100 ml. Serum magnesium low, value 1.71 milligram per 100 ml. Range 1.8 to 2.6 milligram per 100 ml. CT scan brain shows the bilateral supra and infratentorial basal ganglia calcifications. EEG shows the generalized cerebral dysrhythmia. MRI brain shows the T1 hyperintense areas and blooming artifacts in the bilateral dentate nucleus, basal ganglia, bilateral frontal lobes, subcortical fibers, suggestive of the calcifications, DD, Fahr's disease, or hypoparathyroidism. This is the image of the MRI brain of the child showing the bilateral basal ganglia calcifications. Other investigations like the CBC, serum urea, serum creatinine, LFT, T3, T4, TSH are within normal limit. Differential diagnosis, parathyroid dysfunctions, mitochondrial diseases associated with brain calcifications, infections like the torchage, TB, meningitis, encephalitis, recent trauma, calcified angiomas, toxic causes, neurocystic sarcosis, brain tumors. Case summary. A 15-year-old male patient present with the follow-up case of the seizure disorders with slurring of speech and progressively increasing episodes of the muscle spasm and uncontrolled movements, along with the slur of speech and some behavioral problems. On investigations and imaging, we approach to rule out the differential diagnosis like parathyroid dysfunctions, mitochondrial diseases associated with brain calcifications as high PTH and low calcium, so no signs of tetany and somatosensory visual brain stem audiometry responses. Infections like the torchage, TB, meningitis, encephalitis rule out because of the low CVC, low normal CVC counts and no signs of the meningeal irritations and normal CSF finding. So it is not the case of the TB, meningitis, or encephalitis. Recent trauma like the negative history of the trauma, calcified angioma in MRI and CT brain, no calcified angioma seen, toxic causes like the absence of any toxicity in the blood. Fahr syndromes. Fahr syndrome is an inherited genetic disorder characterized by the abnormal deposits of the calcium in the brain areas, which control the movements. Calcium deposits in the basal ganglia, cerebral and cortical regions, leading to atrophy. This middle deposits causes the significant neuron loss, leading to the motor and mental disabilities. Etiological manifestations like the endocrine disorders, adult onsets, neurodegenerative conditions, infectious diseases, inherited or early onset syndrome. Clinical features, neurological, movement disorders, and neuropsychiatric features. Neurological disorders like the features seizures, loss of consciousness, gait disorders, speech impairments, dementia, chorea, features dance like movements, attitude tremors, and movements, papilledema of the intracranial hypertension. Movement disorders like the unsteady gait, clumsiness, involuntary movements, muscle cramping, neuropsychiatric features like the psychosis, depressions, deteriorations of the intelligence, inability to make the decisions. Diagnostic criteria for the Fahr syndromes: bilateral calcifications of the basal ganglia, progressive neurological dysfunctions, free from the mitochondrial, metabolic, or other systemic diseases, absence of the infectious, toxic, or traumatic cause, autosomal dominant inheritance. Managements: No particular proven management in the Fahr disease. Early diagnosis and treatment of the cause may abate the calcification process. Symptomatic management done to comfort the patients. Anti-epileptic for the seizures, corrections of the calcium, phosphates in case of the hypoparathyroidisms. Early treatment of the hypoparathyroidisms reverse the mental retardations. Take home message. Breakthrough or recurrent seizures should always be evaluated very carefully. Associated neurological clinical manifestations should always be evaluated to see whether it is a gray matter problem or white matter problem. Fahr syndrome is inherited, but family history may be absent. This is the pictures of the child. Consents have been taken from the parents. Thank you, sir.
Thank you, Dr. Akhilesh, for your nice presentation, recurrent seizure with rare disease.
Thank you, sir.
Our next presentations will be done by Dr. Shamim Akhtar Ghazi. The case is rare skin disorder, misdiagnosed as JIA. So I would like to invite Dr. Shamim. Please, over to you, Dr. Shamim.
Good afternoon, everyone. I am Dr. Shamim Akhtar Ghazi, DNB PGD, Department of Pediatrics, Diamond Harbour Government
একটু
Medical
জোরে বলো,
Hospital.
শোনা যাচ্ছে না, একটু জোরে বলো।
Today I am presenting a case, a rare skin disorder misdiagnosed as JIA.
মাউথ পিসটা নিচে নেমে গেছে, মাউথ পিসটা কাছে নাও।
Sir, am
Yeah.
I audible? Sir, শোনা যাচ্ছে?
হ্যাঁ হ্যাঁ বলো।
A 5-year-old girl from Usti, chief complained with severe pain and progressive deformity involving the large joints for last 1 year and skin lesion on face and trunk for last 1 year. History of present illness. The patient was apparently well 1 year back. Initially, she developed a few blistering of skin lesions on face and trunk. This was associated with severe joint pain involving large joints and progressive deformity. Small joints of hands and feet were spared. This is a picture of the child showing the pain and deformity was so much that she was unable to stand straight on her feet. This is another picture showing macular hypopigmented and hyperpigmented scars of various sizes were noted over the exposed part of the body. This is another picture showing skin lesions with granulation tissues were found over her face and trunk. Nails were dystrophic in all 4 limbs. Oral mucosal ulceration and enamel hypoplasia were also noted. No swelling, crepitus, redness, tenderness noted in any of the joints. There was no sensory loss or nerve thickening. Past history of repeated respiratory tract infections were present. History of peeling of skin either spontaneously or following trivial trauma since post-neonatal age. Family history showing 3rd-degree consanguineous marriage. No history of similar illness in family members. Birth history, development history were non-contributory. Immunization was up to date. Treatment history showing she had received a few anti-inflammatory drugs and methotrexate for 6 months following up diagnosis of oligoarticular GIA by specialist physician without any improvement. Come to the examination. The patient was alert, conscious, cooperative. Pallor, cyanosis, icterus, clubbing, edema not found. Vitals were normal. Cutaneous examination showing macular hypopigmented and hyperpigmented scars of various sizes were noted over the exposed part of the body. Skin lesions with granulation tissues were found over her face and trunk. Musculoskeletal system examination showing decreased joint mobility along with flexion contracture in large joints, especially in both knees. Spine showed thoracolumbar kyphoscoliosis. Oral examination shows ulceration and enamel hypoplasia were also noted. Systemic examination shows soft hepatomegaly 3 cm below right costal margin, other was normal. Blood investigation showing hemoglobin 9.8 gram per dl, total leukocyte count 11,900 per cubic millimeter with neutrophilic predominant, and ESR was 56 mm in first hour. Anti-nuclear antibody rheumatoid factor with complements were within normal limit. USG shows large joints were normal with no effusion or synovial thickening. X-ray thoracolumbar spine showing thoracolumbar kyphoscoliosis. This is the X-ray of wrist joint showing no bony erosion or periarticular osteoporosis, but delayed bone age corresponding to 3 years of age as per Gruelich pile chart. This is the chest X-ray showing normal lung and cardiac shadow, but scoliosis noted. Skin biopsy, direct immunofluorescence study of skin biopsy was negative. Skin biopsy from mechanical induced lesion showed split at the level of lamina lucida. Antigen mapping confirmed the subepidermal split in the section studied. Linear staining of basement membrane zone with monoclonal antibodies against type 4C7 collagen and laminin 332 are seen on the dermal side, while with BP230 it is seen on the epidermal side. Skin biopsy was sent in the SESCAM. The intensity of staining is comparable to that of normal human skin, which is used as a control. It practically rules out dystrophic and junctional generalized variety of epidermolysis bullosa. Mutation study of LAMA3 gene could not be done due to financial constraint. So she was diagnosed provisionally as case of localized junctional epidermolysis bullosa. Management. Parents were counseled regarding the dermatological problem and absence of any joint disorder. Patient was treated symptomatically with soothing agent, analgesics and physiotherapy. Take home message. Clinician must be aware of the fact that restriction of the movement and deformities may not be always the joint disease. Subtle clues like skin, nails and dental findings may point towards a different diagnosis which should not be overlooked. Thank you.
Thank you, Dr. Shamim, for your nice presentation. Now the session of a Q&A and the discussion part also. Sir, any question? There is one question already. I think the answer has been given by Dr. Tom.
Let me explain the answer and the question. The question is reduced platelet count in Kawasaki disease. I don't identify the sender of the question. So the thing is that in normally in Kawasaki disease, what happens in the first week, the platelet counts remains normal, and usually it gets raised in second week. But in certain patients of Kawasaki disease, we may get thrombocytopenia. And that thrombocytopenia usually indicates a bad prognostic factor. And in our case, what happens due to dengue, there is a platelet destruction in the earlier part. So, you know, in the dengue, there is a thrombocytopenia. So in the first week, you are getting a low level of stop screen share. In the first week, we get a low level of platelet because of the dengue, because platelet count was low. But usually in the second week, when platelet count usually get raised, but due to the pre-existing dengue, there is a low platelet, so we could not get the high platelet level. That was one of the important findings in our case. And there is one reference, I think Dr. Tanmoy has found out this reference in Dr. Piyush Gupta. One case report was there that they have also found that this resultant platelet actually is a resultant platelet, that there is no rise in the platelet that's why it was very difficult to diagnose the Kawasaki disease in our patient, because it is the incomplete Kawasaki disease, and as well as since the patient presented with the dengue and there is a low platelet count and there is a bleeding and so acute, we could not even think of Kawasaki disease initially. But in the second week, when the fever does not go away, usually what happens in the dengue, when platelet count goes down, it is in the critical phase. When the critical phase is over, usually fever usually passes off. But the catch is there in this case that the fever does not go away. That's why we are very inquisitive about any other coexistent disease. And on the day 6 and day 7, we got that perianal excoriation along with the periangual excoriation that raises the suspicion of existing Kawasaki disease. So that was the key presentation of our case.
Actually, Shumantro, there was a clue in the history. There was pyuria.
Yes.
And there was some mucosal erosions initially. So pyuria, he has written it nicely.
Yes.
Pyuria with the
Pyuria,
that
and that is another feature. That is also another feature of Kawasaki disease, but that is not a clinical feature. That is usually by investigation. After being admitted in a hospital, when investigation report came, then we could get that there is an increased amount in a number of pus cell. Clinically, it was not evident.
Anyway, nice cases throughout. Fahr syndrome disease is really nice. So you could do all this investigation even in the Diamond Harbour Medical College. That is good, and even the skin biopsy report that are given.
No, actually, skin biopsy report. Actually, skin biopsy was done at SSKM hospital. We have mentioned. Dr. Shamim has mentioned that skin biopsy report has been done in the SSKM hospital. Because the direct immunofluorescence study is not done in our hospital, we have sent the sample there, and they can go. We have got the report from SSKM pathology department, so we acknowledge that it was. And in that case also, the skin biopsy usually distinguish between the dystrophic epidermolysis bullosa and junctional epidermolysis bullosa, because in our case also we got dystrophic nails, we got enamel dystrophy in the nail in your teeth also, but we initially thought it could be a DEB, but later on when the skin biopsy we have got the skin biopsy, and it showed the subepidermal split, and that was the catch there. But LAMA3A mutation could not be done because of the financial constraint. So that's why it is a localized variety of JEB that presenting with the joint diseases. Joint deformity was there, pain was less, deformity was so much so that patient could not even stand. You have seen the photographs. So it was a presentation like that, but the skin presentation was a catch, but initially it was missed by the specialist pediatrician outside that there's some skin disorder is there. So that is our point of discussion, that we must look at the skin before stamping the patient to be JIA.
So I'll request Dr. Sumik Hajra is there. So and Sumantra also, you can directly message me the first and second. As usually we give the prizes, a certificate for the first and the second. So I think we will be 3. You can post directly to me, Sumik and Dr. Sumantra, so that we can decide who will be the first and who will be the second. In the chat box, you can do the direct message.
There's one message we are getting here that JV should get the first prize.
No, Sumantra, let decide.
Okay.
Shomik?
Shobanda, I have messaged you in WhatsApp.
Okay. Sumantra, you can message me in the WhatsApp. Thank you, Dr. Patra. we are trying our best to reach to the periphery. Even the clinical meeting should happen in every corner of West Bengal. And that's why it's happening this time in Diamond Harbour Medical College. Okay. So with all opinion, that JEB that is presented by Dr. Samim Akhtar Ghazi, he will be getting the first prize of the certificate, and the second prize will go to that Fahr syndrome. And the presenter was Dr. Akhilesh Kumar Singh. Okay, so big round of applause for them because they have done a splendid job.
Thank you, sir. Thanks a lot. And we are
Thank you.
we are feeling proud. It is happened only under leadership of our HOD, Professor Dr. Sumanto Sarkar. And I would like to thank you, IAP, President, Secretary, and the Scientific Chairperson for giving the Diamond Harbour to give us such nice presentation. So thank you, sir. Thank you all, PGT. And sir, over to you, sir.
It's a great pride for us that we have presented our case, and our captain is that good when the team members are good. So it is actually the team members who have done it. So under the leadership of Dr. Rahul Islam and other visitings are also there. Our students have done really well. They are doing it the first time. So they are a bit inexperienced. Hopefully they will make it up in the next meeting. And it's a great honor for us that as a peripheral medical college, also we are participating in this West Bengal Academy of Pediatrics clinical meeting. The whole credit goes to the team of West Bengal Academy of Pediatrics under the leadership of President Ma'am Kalpana Ma'am. And thank you, Dr. Shapon Kumar Rai, the scientific chairperson, very enthusiastic and energetic. Thank you, Shaponda, personally, and your blessings. With your blessings, I think the audience have enjoyed our academic meet. Thank you all. Thank you.
Thank you, Sumantra. I must thank all the presenters and all the attendees who have attended this online clinical meeting. So, and I must personally thank Dr. Sumantra for taking the pain, and also to Dr. Rahul Islam for mentoring the entire program. And thanks, Somnath, for giving
great that Atul sir has participated in the meeting from Toronto.
Thank you, sir. Sir, need your blessing. There is always room for improvement. So definitely in the coming session, we will also try to improve ourselves. And mainly it happened.
Sir has participated in our meet from Toronto. He has given the message at 5:03 a.m. Atul sir has messaged. Okay. Thank you, sir. Thank you very much, sir.
Thank you, sir. Thank you, Shabun sir. Thanks a lot, sir.
Okay. So we call it a day. Thank you.
Okay, sir. Okay.